أهلا بيكم. In this lecture, we are going to study the heart. So let's begin. The mediastinum, it's a central portion between the vertebra posteriorly and the back of sternum anteriorly. Means that, for example, anything besides the vertebrae does not belong to the mediastinum. So always think of it like that. It's the area, central area behind the sternum, anterior to the vertebral column, and surrounded by the lungs on each side. So what are the boundaries? All this is the mediastinum. A plane passing through the second rib angle of Lewis of the sternum to the disc between T4 and 5 divides the mediastinum into superior mediastinum and inferior mediastinum. Now, in the inferior mediastinum, you have the pericardial sac that contains the heart. So it further subdivides the inferior mediastinum into anterior mediastinum, middle mediastinum, which is the heart itself and the pericardial sac, posterior mediastinum, which is behind the pericardial sac. So when we are talking about anterior, middle, and posterior mediastina, we are talking about the inferior mediastinum actually. Okay, don't get confused. The superior is above the plane passing between the angle of Lewis and the disc between T4 and T5. Okay? Now, let's study each part separately. We'll start with the anterior mediastinum. It's posterior to the body of the sternum and anterior to the pericardial sac. Of course, this is not a sagittal section here. This is a parasagittal section to the right side of the pericardial sac to show you the whole thing. We said it's limited above, the anterior mediastinum limited above by the transverse plane, and it has the mediastinal pleura on each side. This is logic. The contents are actually in adults the remnants of the thymus gland. In young children, there is a thymus gland that extends to the anterior mediastinum, fat and connective tissue, and a ligament that connects the pericardial sac to the back of the sternum called the sternopericardial ligaments, and the branches of the mediastinal branches of the internal thoracic vessels in this area. So we are talking about this area only. This is plain and simple, nothing more than you expect here than other than the ligament and the remnant of the thymus gland. Now the middle mediastinum, which is the main issue, we'll be talking about the heart here. It has the pericardium, the heart, and the origins of the great vessels. So the ascending thoracic aorta and the beginning of the pulmonary trunk is counted as a content of the middle mediastinum, while the rest belong to the superior mediastinum. Okay, so when we talk about the ascending, the first part of the ascending actually thoracic, and with the first part of the pulmonary trunk, or the pulmonary trunk itself, not the pulmonary arteries, we're talking about the medial mediastinum, but the superior mediastinum are the pulmonary arteries and the arch of the aorta. Now you are oriented. Okay, so for the pericardium, it's two sacs. One plain sac at the outside called the fibrous pericardium, and the heart with its covering is lie in that sac. Okay, this is not the same like the pleura and the peritoneum we will study later, that you invaginate the sac from the outside. No, this is simple. The heart with its covering inside the sac, the pericardial sac. This is the fibrous pericardium, and we have the covering of the heart from the inside is the serous pericardium. This is a sac that got invaginated by the heart and vessels. So it has a parietal and visceral layers which are continuous at sites of reflections. We will be study this. The parietal layer sticks to the fibrous pericardium, and the visceral layer applied directly onto the heart. Okay, and as we said, they are continuous. Now, about the fibrous pericardium, it's a bag, rests on the diaphragm, and actually it's fused with the central tendon of the diaphragm and anteriorly by the pericardiosternal ligaments or the sternopericardial ligaments. And you will find the phrenic nerve and the pericardiaco-phrenic vessels accompanying the phrenic nerve are embedded in the wall of the pericardium and supplies it. So the fibrous pericardium is supplied by the phrenic nerve. Remember this, okay? Because sensations taken by different nerves means pain referred to different areas. This is why you should know the nerve supply. For example, before I forget, a simple pain in the epigastric region of the abdominal wall, and unfortunately this is the only place which has pain in myocardial infarction, for example. Myocardial infarction represents itself other than the typical pain in the shoulder and radiating to the upper limb and in the retrosternal pain. No, sometimes, actually many times, and I've seen this as just a pain in the epigastric region. So always put in mind the nerve supply of the pericardium and the pleura and how the pain is referred. This is very important. Okay, this is about the fibrous pericardium. This is a slide. I just want you to get familiar with some embryological terms, like the truncus arteriosus and bulbus cordis. See, the heart and its vessels were a tube before, and this tube you bent it on upon itself and twisted it. So actually the heart with its coverings, you will get an area, a passage between the two coverings. For example, this is a transverse sinus. You will get an area of reflection of serous pericardium, which we'll talk about the oblique pericardial sinus. But during our study with the different parts of the heart, we will mention the bulbus cordis, for example, truncus arteriosus, and observe here the truncus arteriosus and bulbus cordis. This will give the pulmonary trunk and the aorta later. And the ventricles, the primitive ventricles and primitive atria, will become the ventricles and atria. And look at the atrial side here of this tube. There is a part called the sinus venosus that will form the great, actually, vessels, venous side, and will be incorporated, a part of it, into the atria, the smooth part of the atria. So just to be familiar with these terms, okay? The truncus arteriosus, bulbus cordis, and how the tube developed and bent on itself, as you can see here, and twisted. You don't need to learn exactly how it got twisted and bent to figure out the reflections, but just to have an idea now that it was a simple tube, and the tube got bent on itself, and part of it got twisted on itself to form the heart. Okay, now we're done with the fibrous pericardium. Let's study the serous pericardium. It's reflected superiorly around the arteries, the aorta, and the pulmonary trunk, and posterior around the veins, like the superior inferior vena cava, the superior vena cava and inferior vena cava, and the pulmonary veins. Now, the you can see here that this is the fibrous pericardium opened, and together with it is the parietal layer of serous pericardium opened. See, so the scalpel cut the fibrous pericardium and the parietal layer. You can see here an inverted U-shape cul-de-sac reflection of the serous pericardium. This is called the oblique sinus. The surgeon just have to put his finger behind the apex of the heart and it slips upwards directly into the oblique sinus. So this is the oblique sinus. Okay, now what's in front of the oblique sinus? The left atrium is a direct relation. The left atrium lies here. And what's behind it is the esophagus. This is an extremely important piece of information, that behind the left atrium is an esophagus, because patients may represent to you with a simple symptom of dysphagia. The patient tells you that he has some difficulty passing food to his stomach. He feels that it stops in the middle of his chest. You don't go directly to investigate just the esophagus. No, it may be a hypertrophy in the heart, left-sided hypertrophy, atrial hypertrophy, that is compressing the esophagus. So you do an X-ray lateral view with a barium swallow to confirm this. You will find the compression on the esophagus by the left atrium. And what's separating the left atrium from the esophagus? The oblique myocardial or pericardial sinus. Okay, the transverse sinus is behind the great vessels, the pulmonary trunk and the aorta. If you put your finger behind them, see this reflection here? This is the transverse sinus. You're putting your finger here. It will be in front. There will be pericardial will be serous pericardium, and behind you will be serous pericardium, and at the same time you will be separating the veins, the superior vena cava pulmonary veins, from the pulmonary trunk and the arch of the aorta. This is the pulmonary trunk and this is the aorta. This is the superior vena cava. Okay, the vessels and nerves that supply the pericardium: we have the internal thoracic with its pericardiaco-phrenic branch. Branches from the aorta, the superior phrenic, supply the pericardium, and the venous drainage follows the arteries to their sources, of course, to the, not to their sources, but to the azygos and internal thoracic, actually. And nerve supply are the phrenic for the somatic sensations, and the vagus and sympathetic for the autonomic sensations. Now, because it's supplied by the phrenic, C3, 4, and 5, pain will be referred to the areas supplied by the same nerve roots, which is the supraclavicular region of the shoulder and the lateral neck. Okay? Okay, now we have a case of pericarditis. Inflammation of the cardiac coverings means that there will be an inflammatory reaction and exudate developing, and it will be in the pericardial cavity. Now, where does the pericardial cavity lies? It lies between, remember this, the parietal and visceral layers of the serous pericardium. So it's totally in the serous pericardium. Now, this will affect, of course, the heart. The reason there is a pericardial cavity that's filled with a thin film of fluid to facilitate the movement of the heart. It's in continuous movement. So for the easy gliding of the heart, contraction and relaxation. But if there is an inflammation, this will impede, of course, the contractions of the heart. It's diagnosed by a characteristic pericardial rub heard by the stethoscope, and if this developed into develops, the exudate is a lot, or more commonly in a hemopericardium, where there is a stab to the heart. Blood will accumulate in the pericardial cavity and compress the heart. This is called the cardiac tamponade. The heart will stop. So it's a fatal case, of course. Okay. The heart itself is a pyramid in shape. It has an apex. It has a base posteriorly. The base is formed by the left atrium mainly, and the apex is formed by the left ventricle. It has an anterior surface, sternocostal surface, inferior diaphragmatic surface, and right and left pulmonary surfaces, as you can see here. The base, this is the base of the heart, formed mainly by the left atrium. Okay, with its with the veins going inside or emptying into the left atrium, and the part of the greater veins like the superior and the inferior vena cava veins. Okay, so this is the base of the heart. It lies opposite vertebral levels T5 to T8, and we talked about the barium swallow to diagnose a left-sided hypertrophy, especially atrial hypertrophy. Okay, the apex of the heart is formed by the left, not mainly, it is part of the left ventricle, and it lies in the left fifth intercostal space, mid-clavicular line. You must mention the mid-clavicular line because the space is a big space from front to the back. So exactly left fifth intercostal space, mid-clavicular line. The anterior surface of the heart is mainly by the right ventricle, little by the left ventricle, and by the right atrium. Diaphragmatic surface, the one you see here, mainly by the left ventricle and little by the right ventricle, with the posterior interventricular sulcus in between, okay, with the vessels in it. And the left pulmonary surface is by the left ventricle. The right pulmonary surface is by the right atrium. It's easy. You don't have to learn things by heart. Just picture the heart in anatomical position, and remember the left ventricle encroaches forwards. Okay, so you will get the whole thing without learning it by heart. This is simply the surfaces of the heart. Now, borders of the heart. Of course, the heart is a blunt, oval mass, continuous mass, which has no borders. No, but we are talking here about the borders you see called the shadow, the cardiac shadow, because changes in different parts of these borders may indicate what's happening inside. For example, the right border of the heart, as you can see here, formed by the superior vena cava and the right atrium and the inferior vena cava. So let's apply this here. This is the border of the right atrium. Here the inferior vena cava, and this part is the superior vena cava. If you noticed any increase in size, for example, in this shadow, this means right atrial hypertrophy. So it's important, even by a plain X-ray, to assist you in diagnosis of the heart condition. This is the right border. The left border is formed by, see here in this specimen, arch of aorta. This arch here, this is called the aortic knuckle. Aortic knuckle, you can identify it in the X-ray, this one, by the end of the arch and beginning of the descending thoracic aorta. Okay, below the arch you have the pulmonary trunk, right? So a little below here is the pulmonary trunk. And then you have the left auricle, which is extension of the left atrium. So this is the left auricle, and the rest is by the left ventricle. Okay, this is the left border of the heart. Inferior border is by the right ventricle, see, and the apex. Right ventricle and the apex. If you need to visualize the left atrium, you need to have a lateral view, chest X-ray lateral view, to visualize the left atrium and its intimate relation with the esophagus behind. Okay, on the outer surface of the heart we have sulci, like the coronary sulcus, which has the coronary sinus, the circumflex branch of the left coronary artery, the small cardiac vein. They run in the sulcus. It surrounds the heart and separates the atria from the ventricles. This is the coronary sulcus. Okay. You have the anterior interventricular sulcus that has the anterior interventricular artery in it with the vein, the great cardiac vein. You have the posterior interventricular sulcus, which has the posterior interventricular artery and the middle cardiac vein in it. Okay, so you have anterior and posterior sulci, and as you can see, they are continuous just to the right of the apex of the heart, which is made or formed by the left ventricle. These are the sulci you will find on the external surface of the heart. Okay, let's proceed. Now, yes, the picture is tilted because I wanted to put the heart in anatomical position. Okay? Chambers, we have 4 chambers, as you know. 2 on the right, 2 on the left, and the right and left side this is a misnomer. Actually, there are no more right and left. There are anterior and posterior. Please put this in mind. It was before, during development, right side pump and left side pump, but this pump got twisted to the left, so the right side became anterior and the left side became posterior. Don't forget this. Okay, we are looking at the inside of the right atrium. The right atrium, of course, receives its blood from the superior and inferior vena cava. These are the openings of the superior vena cava, inferior vena cava. You can notice a valve, small valve, remnant of a valve actually, in the inferior vena cava opening and the coronary sinus opening, which you can see here, just medial to the inferior vena cava opening. Okay, what you see here is actually the interatrial septum. It is the posterior wall of the right atrium, and at the same time it's the anterior wall of the left atrium. Now you're oriented, right? Because we're looking directly through from the front through the right atrium. We are cutting the anterior wall. You'll notice a crest here called the cresta terminalis. This marks the difference between the proper atrium in front and actually you can call the false atrium, or the part of the atrium that belonged to the vessels before and got incorporated in the atrium. As you can see, the major difference that the proper atrium is rough surface because of what's so-called the trabeculae carni coming out of the the musculi pectinati coming out of the cresta terminalis. Musculi pectinati, you can see here, coming out of the cresta terminalis, and the smooth part which belonged to the vessels before and got incorporated into the wall of the atrium. Now this cresta terminalis, on the outside it has a sulcus opposite to it on the external surface called the sulcus terminalis. So the sulcus terminalis marks the inside cresta terminalis in the right atrium. At the interatrial septum, at the base, you can find the opening for the coronary sinus, which is the major venous drainage of the heart, which has a remnant of a valve also. You can find the fossa ovalis. This is the fossa ovalis. This is a remnant of the, in embryology, of the septum secundum to form part of the procedure or the steps in formation of the interatrial septum. And the fossa ovalis has an edge upwards that belong before to the septum primum. This is called the limbus fossa ovalis. So limbus fossa ovalis guards the fossa ovalis. This fossa was open before to allow for the passage of blood from the right side to the left side to be pumped to the body of the fetus, and it closes at birth. At the moment the newly born takes his first breath, some changes occur in the body. One of the changes is the closure of the fossa ovalis. Okay, it was actually it's not a hole; it's a valve-like piece. Okay, that opens whenever blood pushes on it and goes to the left side of the heart. Okay. You can also find minute openings in the walls of each chamber. Actually, these are the openings of the venae cordis minimi, which are a small system of veins, very minute veins that drain the cardiac muscle directly in the chamber. Why? Of course, we have an extensive venous drainage because we don't want to accumulate metabolites in the muscle wall of the heart that contracts forever. Okay, never stops. Okay, the right ventricle, we came from the right atrium to the right ventricle through the tricuspid valve. Tricuspid means it has three cusps. Okay, this is the inside of the right ventricle. You can see that it has a smooth part upwards called the conus arteriosus or infundibulum that will give rise to the pulmonary trunk. Okay, so this is the outflow direction, this is the inflow direction. See, they are perpendicular to each other. This is the inflow, this is the outflow. The outflow should be smooth here. Okay, and the rest of the ventricle is rough by what's so called the trabeculae carni, elevations from the cardiac muscle. Some of them are attached in two ends, making bridges. Why do we have the trabeculae carni? Actually, it was found that these bridges and elevations and depressions, they slow down the heart, the blood coming from the right atrium, and prepares it to be expelled into the pulmonary artery in the outflow direction. What else? A few of these trabeculae carni are enlarged and form papillary muscles. See, this is a papillary muscle. Papillary muscle. Each muscle has minute chorda tendini that attaches to the cusps, and for a while it looks like the papillary muscle pulls on the cusps to open it. This is not what happens, or our life will be dependent on this muscle. What happens is, during contraction of the heart and after the blood filled the right ventricle, and the ventricle is contracting to expel it into the pulmonary trunk, the pressure, high pressure, will push on the cusps as well. They will go back, go upward again in the into the right atrium. The papillary muscles prevent such movement. They pull on the cusps and prevent them from going upward because they are simply cusps. They can move in any direction. Okay, so prevent the cusps of the valve to go upwards in the right atrium, and the valve gets open again. So as if you're doing nothing. The contraction, the blood, instead of going totally to the pulmonary trunk, will go back again to the right atrium, and this is not, of course, what happens, what should happen. Okay, one of the trabeculae, again, instead of becoming a papillary muscle, one of them becomes enlarged to form the moderator band, or the septomarginal trabecula, that if you dissect this part, you will find the right bundle branch, the part of the conducting system of the heart that will excite the walls of the right ventricle. It's called the moderator band. Okay, so this is about the right ventricle. We talked about the trabeculae carni, the papillary muscles, the cusps, and the outflow. Okay, the conus arteriosus. These are the parts in the right ventricle. Now the tricuspid valve, tricuspid means three cusps, has three leaflets, anterior and posterior and septal, anterior, posterior, septal. Okay, and each cusp is connected by chorda tendineae to a papillary muscle. Now, in case of myocardial infarction, and one of the papillary muscles got necrotic, became necrotic, necrosis, of course the cusp will be without control. So it will backflow into the atrium with contraction, and this is called prolapse of the valve. Prolapse of the valve means no control on the cusps anymore by the papillary muscles. Okay, so that's why you always get, sometimes with severe infarctions, you get extra heart sounds or extra murmurs you hear by the stethoscope because of the prolapse of the valves. The pulmonary valve has a different story. It's not connected to papillary muscles. It's simply three pockets. And this arrangement we call the valve semilunar valve. Three pockets. Each pocket has a free edge. This free edge thickened to form the lonule of the cusps, and at the middle there is a nodule on the lonule. Why the nodule is there? I want you to imagine these cusps are put back again. So because they are arched, if you put it back again, there will always be a defect in the middle. Okay, because they are arched. If you put this back again on itself, there will be an arch and an arch and another arch, and in the middle will still not be covered. So the nodules completes this task, complete the closure of the cusp. What happens is, when the blood flows into the pulmonary trunk, or at the other side into the aorta, of course it will go back again, falls into the pockets, and force the valve to close. Force the valve to close without the need for papillary muscles to prevent its. It's a totally different technique here for this type of valve. They are called the semilunar valves. Okay, the pulmonary valve has a left and right and anterior cusps, and we talked about the composition of these cusps. Well, the left atrium, you have the back side of the fossa ovalis, of course, smooth side that that was incorporated from the veins that open into the atrium, and a rough part, rough part, some musculi pectinati, especially in the auricle, of course, but there is no crista terminalis. There is no crista terminalis into the left atrium, and in this case, in the left atrium, the interatrial septum is the anterior surface of the left atrium. Okay, the left ventricle, anterior to left atrium, and it has the thickest myocardium because it pumps blood against the resistance of all the vessels in the body. It must supply all the body. So it must have a strong, efficient pump. That's why it's the thickest myocardium for the left ventricle. The outflow of blood through the aortic opening, the aortic valve guarded by the aortic valve, which is a semilunar valve, the same arrangement like the pulmonary one, and also the part that's before the aortic opening is smooth, not like the rest of the ventricle. It's called the aortic vestibule, and it was derived from the bulbus cordis. See, we are using embryology terms here. Bulbus cordis. The difference than the right side is that the trabecular carni are thin and delicate, and we have two papillary muscles for the two cusps of the mitral valve, or the bicuspid valve, the one that separates the left atrium from the left ventricle. Now, the anterior wall of the left ventricle is the interventricular septum. The posterior wall of the right ventricle was the interventricular septum. The septum is characterized by having a major part, which is muscular, and an upper membranous part. So it has an upper membranous part, and almost all of it is muscular. So the membranous part is small, actually. Okay, but it's there. It does exist. Okay, upper membranous part and a muscular part for the interventricular septum. Now, what separates the left atrium from the left ventricle is the mitral valve. It's a bicuspid valve, as we said before. It has an anterior and posterior cusps, okay, connected by chorda tendinae to papillary muscles. The same action, the same mechanism of action like the tricuspid valve, the same theory. The aortic valve is a semilunar valve that has the three pockets, okay, right and left and posterior semilunar cusps. But the difference here, in the cusps, we have in the wall a sinus that will give rise to the coronary arteries. We have a right coronary sinus, left coronary sinus, under the right cusp and the left cusp. Now the middle one, the posterior one, has no sinus in it, so it's called the non-coronary cusp. Remember the aortic sinuses. Now, see the genius design here to make sure that the heart is always perfused by blood at any period of time. The blood, even when the ventricle contracts and the valve is open, okay, the blood flows out, and after that the blood comes back and fills the sinuses. So actually the heart is fed during relaxation. You got the idea? During diastole, the heart gets fed during diastole. Why the blood falls back and goes into the sinuses, but during contraction, during systole, the cusp, occlude the sinus, and the blood flows out of the aorta. This is how the heart feeds during diastole. Okay, this is about the aortic valve. The auscultatory areas. Where do you put your stethoscope to listen to the heart? It's not, doctors, it's not the surface anatomy of the valves. If you're talking about surface anatomy of the valves, you will get 4 points on the sternum, starting with the pulmonary, then the aortic, then the mitral, then the tricuspid, ending at the xiphoid. This is not the case here. You don't listen on the sternum. What you do is you put the stethoscope in the face of the blood flow. So the blood flow directly towards the stethoscope to be able to maximally hear the door that this blood is coming out from. You know what I mean? So you put the stethoscope in front of the valve in front or against the blood flow that's coming out of the valve to listen to the condition of the valve. So to listen to the aortic valve, you have to put it, the aorta, see, it goes this way and then the arch. So you put the stethoscope high up here on the right, in the right second intercostal space, to listen to blood hitting your stethoscope. If you want to listen to the pulmonary valve, the blood goes this way in the pulmonary, right? The pulmonary first goes to the left and then divides into pulmonary arteries, so the blood goes this way. So you put the stethoscope against the flow in the left second intercostal space to listen to the pulmonary valve. Now for the xiphisternal junction for the tricuspid valve, because the blood is coming at this direction from the right atrium to the right ventricle. So you put the stethoscope at the xiphisternal junction, and in the left fifth intercostal space, mid-clavicular line, to listen to the mitral valve. You put it at the apex of the heart to listen to the mitral valve to receive the blood on the stethoscope. So now you understand the auscultatory areas, that it's not the surface anatomy of the valves. Instead, you are putting your stethoscope in front or against the flow of the blood towards you. Okay? Okay, so this is it for this lecture. We talked about the structure of the heart. Next time we'll talk about its blood supply and nerve supply. I hope you got the maximum benefit from this lecture, and thank you very much for watching.